Okay, let's start this session. 안녕하세요. 제3회 코리안 DCR 디스커션 포럼에 참석해 주셔서 감사합니다. 이 포럼은 오늘 50분 동안 진행이 되겠습니다. 몇 가지 간단한 주의사항을 말씀드리고 그다음 다음 순서로 넘어가도록 하겠습니다. 이전에도 설명드린 바가 있지만 보안 문제로 저희가 해킹을 당하는 일이 있어서 웨비나 등록부터 관리를 시작하도록 하겠습니다. 등록을 통해서 링크를 받은 그 링크를 통해서만 참석을 하실 수가 있겠고요. 현재는 패널리스트와 참가자의 기능이 약간 다릅니다. 네, 질문이 있으신 분은 그 채팅창에 올려주시거나 손을 들어주시면 저희가 패널리스트로 인바이트해서 화면에 보일 수 있도록 하겠습니다. Okay, we have secure consents, therefore we have secure control with Zoom webinar registration. And panelists and attendees features slightly different. If you have any questions, please raise your hand mark and we invite you as a panelist screen and we can see you. 세션은 50분, 45분이 좀 짧아서 50분간 진행하도록 하겠습니다. 영상은 녹화가 돼서 DCR 유튜브 채널에 게시되기 때문에 뭐 동의하지 않으시는 분은 이제 손을 들지 않으셔야 될 것 같습니다. 질문은 가능한 한국어로 해주시면 저희 김영일 인터프리터가 이제 통역을 해드릴 거고요. 영어로 질문하셔도 좋습니다. 근데 영어로 질문하실 경우에는 한국어로 반드시 통역을 같이 해주시기를 부탁드립니다. This session will run for 50 minutes and the session will be recorded and uploaded to YouTube, DCL YouTube channel. And if you are not a Korean, feel free to ask a question in English. Our interpreter can interpret as Korean. 웨비나 이름 변경해 주시면 감사하겠고요. 질문 있으실 때 손들기 마크를 사용해 주십시오. 손들기 마크 사용해 주시면 발언 기회를 드리면서 이 패널리스트 화면으로 초대를 해드리도록 하겠습니다. 현재 참가자는 모두 음소거가 되어 있고 비디오가 꺼져 있는 상태이니까 그렇게 고장이 난 게 아니니 그렇게 알고 있어 주시면 감사하겠습니다. 패널리스트는 모두 비디오에 보이게 되고요. 토론을 하실 땐 마찬가지로 패널로 초대를 해드리도록 하겠습니다. Okay, we just it's not correspond to the foreign attendees. If you have any questions at audience session, please raise your hand feature, and we invite you to the panelist the screen, and we can see you. And okay, attendees video is not active, and no videos and no audios. 예, 오늘 일단 패널리스트를 먼저 소개해드리겠습니다. 오늘 저희가 두 분의 로봇 교육의 아버지 또는 삼촌이라고 할 수 있을 만한 분들인데요. 김진 교수님, 이윤석 교수님, 굉장히 저희 한국뿐 아니고 세계적으로 그 교육 프로그램, 또 수술, 트레이닝에 대해서 굉장히 중요한 역할을 담당해주고 계십니다. 그리고 저희가, 사진이 실물보다 못하게 나왔는데요. 한영 동시통역가로 김영일 교수가 수고를 해주시도록 하겠습니다. Okay, we have two panelists, Jin Kim and Yoon-seok Lee, who are very special robot and minimal invasive surgeons, very experts. They have many teaching sessions worldwide. And please say something to our audience. 김진 선생님, 이윤석 교수님 모두 인사를 좀 해주시면 감사하겠습니다. 김진 교수님 먼저 인사해 주시겠어요?
네, 안녕하십니까. 저는 고려대학교 외과의 김지입니다. 만나서 반갑습니다.
네, 이윤석 교수님 인사 말씀 부탁드립니다.
네, 안녕하세요. 저는 카톨릭대학교 서울성모병원 이윤석입니다. 초대해 주셔서 감사드립니다.
네, 김여현 선생님 아주 간단하게 인사하시겠어요?
네, 안녕하세요. 서울아산병원 조교수 김영일입니다. 네, 반갑습니다.
네, he is in, 지금 이제 미국에서 연수 중입니다. 네, 오늘 스페셜 게스트로는 짐 칸 선생님과 피오치, 구글리엘모 니콜로 피오치 선생님 모셨습니다. 짐 칸 선생님은 굉장히 이제 유명한 영국 서전이신데요. 빌 힐드와 모슨에서 트레이닝을 받으시고 굉장히 로봇 서저리에 대해서 유럽, 영국뿐만 아니라 유럽 전체에서 굉장히 중요한 역할을 담당하고 계십니다. 지금 현재 포츠모스 메디컬 센터의 서저리 디파트먼트를 이끌고 계십니다. 피오치 선생님 같은 경우는 한국에서 트레이닝을 받으신 적이 있으셔서 굉장히 많은 분들이 알고 계실 거라고 생각하고요. 현재 포츠모스 센터에서 일하고 계십니다. 굉장히 이제 많은 페이퍼를 쓰셨고 지금 CV에는 80편이라고 얘기를 해주셨는데 그보다 훨씬 많습니다. 많이 굉장히 액티브한 라이터로도 활동을 해주고 계십니다. We have special guests, Jim Khan and Dr. Piozzi. Jim Khan is a professor of surgery at the University of Portsmouth. He has been trained by a legend like Bill Hill Emerson, and now he is a world-renowned leader of colorectal surgery. Professor Khan is national and European trainer in minimally invasive techniques, specialized in robot colorectal surgery. He plays a very critical role in global surgical research and innovation through key positions in organizations like ACP-GBI, ESAP, and ALS-GBI. We also have Dr. Guglielmo Niccolo Piocci. He's colorectal surgeon specialized in robotic surgeries, now working at Portsmouth University and UK. Many Korean surgeons very well know him, and he trained in South Korea for some time. He is a very active writer and a very active researcher. He published extensively on robot surgery, including sphincter sparing space, preserving techniques, and complete medical excisions. Okay. Jim, could you say something for Korean audience?
Thank you so much, first of all, Professor Park, for your very kind words. I'm very honored at that very kind introduction. Korea has a very special place in my heart too. I did my robotic training in Korea many years ago and have followed a lot of Korean surgeons in Seoul and Daegu and other places. They set very high standards of surgery, and I've always admired how things are done in Korea, the centralization of work, the volume of work and innovation. And I try to visit at least once a year if my timetable allows to come and meet old friends. So glad to see Professor Yeon-Suk Lee and Professor Jin came online as well, who have been very good friends over the years. And thank you once again for this very kind opportunity to join online.
Okay. Dr. Piozzi, could you say something to Korean audience? I just briefly introduced you.
Yeah, thank you, Professor Park. It's an honor for me to be here today. As Prof said, Korea has a huge place in my heart as well. I'm honored to have been a fellow in Korea University, and I'm very happy to be here discussing very important issues.
네, 오늘 같이 토론할 저널은 Impact of Modular Robot Total Mesorectal Excision Training Program on Perioperative and Oncologic Outcomes in Robot Rectal Cancer Surgery라는 제목으로 출간하셨던 논문입니다. 이 트레이닝에 관한 트레이닝이 성과를 냈었다라는 그런 주제의 논문이었고요. 간단히 피오치 선생님이 이제 서머리를 해주시고 난 후에 논문을 서머리 하시면 그 내용은 통역하지 않겠습니다. 서머리 하시고 난 후에 패널 디스커션 시작할 수 있도록 하겠습니다. Okay. Dr. Piozzi, could you just briefly summarize your study? You can share your screen with this.
Yes. Okay, I'll share now. Okay. So thank you very much. So today we'll be discussing about the impact of modular robotic TME training program in perioperative and oncological outcomes in robotic rectal cancer surgery. So first of all, we all know that robotic surgery is rapidly increasing globally, and this is at a very, very fast pace. This creates a problem. The increase in robots means that we have an increase in need for training, and training has to be done in a safe way. To do this in a safe way, we need a structured program, and this creates, again, concerns about the outcomes and the operating times that these structured programs would bring. For this reason, we have done this paper, which was published last year in DC's Colon Rectum. We evaluated all consecutive robotic TMEs from May 2013 to December 2017, and this period was divided in two parts. The first part was operated only by expert surgeons, and the second by supervised trainees. You can see that our robotic TME training program has been divided in 5 modules, which is from the easiest to the hardest in a stepwise manner. Module 1 is just a patient setup. Module 2 is anastomosis and closure. Module 3 is IMA exposure and ligation. Module 4, splenic flexion mobilization. And at the end, Module 5 is the rectal dissection. You can see on the side here, this is just a block visualization. So each trainee, once it's completed a module and he feels capable to perform that in a safe way, according to the trainer, he can go in a stepwise fashion to the next module. So the result from our study showed that in a total of 177 robotic TMEs, 80 were in the first group and 97 were in the second group. You can see here the fellows which were evaluated, which were 4, and the different modules which were completed by each fellow, and the number of total modules. If we see the results, these are very interesting. In fact, the patient's age, sex, BMI, clinical TNM, and neoadjuvant chemoradiotherapy was quite similar between the 2 groups. So there was no main difference between the 2 groups in a clinical point of view. However, if we see on the postoperative results, we can see again, no difference in conversion, no difference in perioperative outcomes, R0 or lymph node harvesting. The only major difference is operating time, which increases by just 25 minutes. That means that if we want to do a supervised training session, we will lose only 25 minutes, and lose is just a very big word, if we can say. If you see about the oncological survival, you can see that the 5-year overall survival and disease-free survival is very, very similar with no statistical difference. And this is quite important. So the discussion we have to do is training in surgical oncology is definitely complex, and the trainers, they always have the burden to deliver an optimal and oncological outcomes, but at the same time, they have to deliver an high quality training. So here, especially in the UK, we have a huge pressure on the service delivery. So having longer operative times because of training can become quite unacceptable on a trust perspective. Therefore, a modular approach can answer this need. In fact, in Portsmouth was the first in the UK to offer a designated continuous fellowship in robotic TMEs since 2015. And we have now over 20 surgeons which have been trained, and now they are successful consultants around the country and in all of Europe, and practice robotic colorectal surgery independently. Therefore, in conclusion, it's very important to see that the modular system is capable to engage with multiple trainees. Not only that you have a surgeon which is in a training pathway that can grow in a stepwise fashion, but you have multiple trainees that can work one next to the other doing the same procedure, but to performing different steps with a different complexity. And this can be done with a very small difference in surgical delivery, just 25 minutes. Therefore, we're not compromising the delivery of surgery. So this is a very important discussion that we should have in the future regarding the training programs. I would like to thank you and go back to you, Professor Park.
Okay. Thank you. Thank you for your great summary, and congratulations for your great work. Okay. Okay, we invite all panel. Yun-Suk Lee, please turn on your video and start our discussions. Okay. We have a panel discussion as the first, and then move to the audience sessions. And at first, as Jim, could you please explain your modular training program in more detail, especially, for example, what kind of subjects or modules are used? I mean, do you use simulation program or animal model for real patients? Were there any kind of time limitation? And like this, please provide a more detailed explanation for your modular program.
Thank you, Professor Clark. If you allow me for a couple of minutes, just to give you a brief background to why we designed this program and why was the need, because in many places, there are different practices, different work pressures, and Dr. Piozzi alluded to some of them already as to what pressures we work with. So in the UK and some of the Western European countries, some of you may be aware, the practice is different from Korea in some ways. We don't have centralized big cancer centers, and most of the cancer practice is done in many, many hospitals around the country. Just to give you an idea that the average number of rectal cancer procedures done by a hospital in the UK is somewhere between 20 to 30 cancer cases per year. And if you compare that with Korea, of course, there is no comparison. When I came to Seoul for my training, I was able to see those cases in 1 month. And hence the volume is very different in UK. It's very small volume as opposed to some other places in China or Japan or Korea. Second thing is, as a surgeon, when you operate, or as a trainee, when you are in training in the UK and in some of the European countries, you only operate 1 or 2 days a week at the most. Most of your time is spent in administrative duties, ward rounds, outpatient clinics, emergency cover. So there is a limitation on your time as to how much you can spend in the operating room, which as a surgeon, you want to do that because you want to learn it. I take you back 20 years when I was in Basingstoke and learning this, and Basingstoke and Professor Heald need no introduction. I was his senior registrar and I worked there for 2 years. The volume that we did in Basingstoke was 30 cancers of the rectum every year. So again, that's not a big number. And when I was in training, in 1 year, I did 10 rectal cancer procedures with Professor Heald, training me and supervising me and teaching me. And that's over 12 months period, which is about 1 procedure every month, which is not a lot of cases. So you have to maximize the experience and the exposure. And I would like to bring in a concept here that traditionally as surgeons, we believe in volume, that volume is the key, repetition and training. But there is an argument for quality as well. Volume without quality is no good. And then I would go one step further, that quality without supervision is not good. So having a high volume training with quality training with supervised fashion, these were the 3 pillars that led us to the concept of developing a modular program. And my famous quote is this, that to be an expert, you need to do the right thing repeatedly in the right way. If you keep doing the wrong thing, you can do it 1,000 times, you will not go and get any better at that. So what we wanted to do was to maximize the opportunities. And again, the practice in UK and Europe is different in a way that we have high BMI patients, we have locally advanced disease, lots of comorbidities. So not every case is suitable training procedure for the trainees to do. And if they were going to spend 6 hours to 7 hours to do 1 case, it is very difficult to keep up with the targets and the pressure. So we had this option of not going through, okay, this is the case that I will do, or this is the case that you will do. We will divide up the case into segments. So I thought that if you're teaching complex scenarios, you break it down into smaller segments and that are easier for you to teach, and it's easier for the recipient to learn. So breaking down the procedure into modules, 5 or 6 of them, depending on how you segment an operation, was then allowing us to teach them in a better fashion. To going back to your original question as to what was the prerequisites before they would start this program. So these are the fellows who have completed their surgical training already. They are not year 1 trainee. They have done 5 years or 6 years of surgical training, so they know how to do an open procedure and a laparoscopic procedure. We believe they have no training on the robot, they have no training on robotic TME, and that's where they start with us. And they spend 6 months in that program. Before they start the program, they will have time to do on the simulator. There are 70 to 80 hours that they have to do on the simulator with 90% scores in all exercises. They have to do console training with a basic robotic skills course. And then they have to do a dry lab with plastic tissue, with cutting, suturing, and stapling, and then a wet lab with animal tissue to use advanced energy and stapling again. And then they go into this program with the modular approach. The beauty of this was that we could train more than 1 trainee at the same time. So the same operation was divided between 2 trainees, or sometimes 3, to give module 1 to 1 trainee and module 5 to another trainee. And then if the case is complex, the supervising surgeon could do the module herself or himself to speed things up, to keep the operating times close. But all of these cases were heavily supervised for each module. And hence we were very keen to look at the long-term outcomes to say, if there is supervised performance to the same standards, does it translate into the same oncological outcomes, which is your 5-year DFS or overall survival rate? And I was very glad to see that there was no difference in those.
김정일 선생님 좀
네,
요약.
간단하게 요약을
네네.
해서 말씀을 드리겠습니다. 일단은 요 모듈을 개발할 필요성에 대해서 먼저 말씀을 해주셨는데, 이제 그 UK, 영국과 유럽에서의 임상이 한국과 많이 다르다는 걸 말씀을 하셨고, 볼륨이 좀 적고, 한 달에 한 20에서 30개의 렉탈 캔서 케이스를 갖고 로봇 수술을 교육하기가 쉽지 않다는 말씀을 해주셨습니다. 근데 제일 중요한 게 이제 코트 해주신 게 엑스퍼트가 되려면은 옳은 일을 계속 반복을 해서 해야 된다고 말씀을 하셨는데, 그러기 위해서 이 모듈을 만들었다고 말씀을 하시고, 이 모듈은 결국은 이제 그 한 수술을 처음부터 끝까지 놓고 봤을 때 세그멘트로 나눠가지고 이제 5개에서 6개의 모듈로 세그멘테이션을 분해를 해가지고 하는 게 가르치기도 쉽고 배우기도 쉽다는 말씀을 하셨고, 이 트레이니들은 그냥 완전 초짜 트레이니는 아니고 한 5에서 6년 정도 복강경 라파로스코픽 서저리를 했지만 로봇 TME에 대해서는 알지 못하는 그런 트레이니들을 대상으로 했습니다. 그래서 박인하 교수님께서 질문하셨던 것처럼 시뮬레이터 70에서 80시간 정도를 먼저 하고, 그 다음에 콘솔에서 또 연습을 하고, 드라이랩에서 스테이플링 뭐 이런 거를 연습을 하고, 그 다음에 동물 랩까지 한 다음에 그 다음에 이제 이 모듈, 연구에서 사용의 모듈로 들어가게 되고, 이 한 환자에서 이 모듈이 5개 정도 모듈이 있을 때, 장점은 뭐 모듈 1을 A 펠로한테 주고, 뭐 3은 B 펠로한테 준다든지 이런 식으로 나눠서 동시에 여러 펠로한테 교육을 할 수도 있고, 요런 교육을 받고 생존율의 차이 크게 없다는 것을 보여줄 수 있다는 것이 좀 좋다고 말씀하셨습니다.
네, 감사합니다. 그러면 패널 선생님들께서도 또 날카로운 질문을 많이 하실 걸로 기대가 되는데 질문 해주시겠어요? 토의 진행해 주시면 감사하겠습니다.
Yeah, good morning. It's Jin Kim from Korea. And I think the significance of this study lies in the fact that it has demonstrated that the modular robotic TME training program has minimized the negative impact on surgical and oncological outcomes, while ensuring the safety and effectiveness in surgical training process. So I'd like to ask how long did the training become accustomed to each module? So another question is is there any the order? Of course, you already answered that you change the trainees module by module. I know is there some segmentation within each modules as well? Is my question.
That's a very
And one more thing. Yeah, please, one more thing. How do you measure the success of each module? Okay. Yeah, that's my question.
Wait a
Thank you.
second. Wait a second, please. 김진 선생님 그 한국말로 질문을 다시 한번 보내드릴게요. Please yes to translate in Korean too.
예.
Please
그래서
wait a second.
저는 3가지 질문을 좀 해보려고 그러는데요. 이런 트레이니들이 이런 그 모듈에 적응하게 되는 게 보통 한 얼마나 걸리는지 하고, 그 다음에 이런 트레이닝을 시키는데 특별히 여기 순서를 보면 이게 이제 서지컬 스킬의 컴플렉시티에 따라서 모듈을 5개로 나눠놨는데, 이런 거를 그 트레이닝 시키는 순서가 있는지, 그 다음에 이런 모듈을 완성했다, 석세스 했다는 걸 어떻게 측정하는지에 대해서 저는 질문을 했습니다.
Okay, please, Jim, Pyoji,
Thank you so much. I would like to thank you for those questions. They're both very, very important points raised by Professor Kim. The first one is about how do you start those modules? And if you look at the division of those modules, there are some parts like the setup, port placement, and docking. And then there is a last module, which is extraction, anastomosis, assessment of the anastomosis, those are the things that these surgeons are very quick to pick up. They may have been doing some of them in their laparoscopic or open surgical practice already. So the learning curve on those modules is very quick. Those are the first, and the module 1 and 5 are the ones that the trainees climb very quickly. The key modules for the whole operation are the module 2, which is the vessel dissection, module 3, which is the splenic flexure mobilization, and module 4, which is the TME. Now, amongst these three, if you ask me, I felt that the difficult learning curve for the module was for the splenic flexure, module number 3, which is where trainees took a lot longer to master that, because there's something they may not be used to. With a robot, you have different setup, so they have to learn a slightly different technique from their laparoscopic procedure. So we started with the module 1 or module 5 to begin with. Then the vessel dissection is the next one they go into, which is quite straightforward, going on to the IMA and IMV and dividing them. And then it's the rectal module, which is easier for people to start and learn because there's less need for adequate tension and progression. And the splenic flexure module takes a bit longer. We have the learning curve graphs on each module. And again, the splenic flexure module had the most steepest learning curve for people to go over. How did we assess their performance of moving from one module to the next? Now, there is a degree of subjectivity, and then there is some objectivity in this as well. As a trainer, when you feel that this trainee has done 4 or 5 modules back to back and they are comfortable and you think that they can progress to the next, you make that call. We do have a video review with that person after the case within the next 48 hours after the procedure. You sit down, you look at the recorded video, and you look at their performance, give them the feedback, and then assess that they can move to the next stage. To bring in objectivity, we use the modified Gears score. We have used them in our laparoscopic training with the LCAT scores. So the thing with scorings and objectivity is that it has to be simple and reproducible. So one page looking at various things and dissection techniques, tissue injuries, errors and complications, and advising them to get better in the next case. One thing I forgot to say is that when we prepare them before they start these modules, they're all given a video as a standard operating procedure, and they have to memorize the steps of those. So it's a very didactic in that way that I don't care how they do it in their own practice, but when they're learning, they have to do things the same way from A to B and B to C. So they have given that video, which is didactic video. They have to learn all the steps and then reproduce them when they do the modules.
예, 그 질문에 대해서 첫 번째 적응 기간이랑 수련 순서가 있는지에 대해서 답변을 주신 거는, 이제 각 모듈마다 적응하는 기간이 달랐다고 말씀을 하시고, 각 모듈마다 이제 러닝 커브가 지금 자료는 있는데 아마 이 논문에는 발표를 안 하신 것 같은데, 예를 들어서 스플래닉 플렉셔 모빌리제이션을 하는 그게 제일 어려웠기 때문에 그게 제일 스티프 러닝 커브를 보여줬다고 말씀을 하시기 때문에 차이는 있다고 말씀을 하시는데, 정확한 적응 기간이 얼마다 이런 것까지 말씀해 주시지는 않았고요. 그래서 순서를 이제 쉬운 것부터 시작을 해서 그 스플래닉 플렉셔를 가장 어려웠기 때문에 마지막에 한 그런 식으로 좀 일련의 과정이 있다고 말씀을 해주셨고, 어떤 기준이 있어가지고 이 트레이니가 다음 단계로 넘어가는지에 대한 것은 객관적인 방법이랑 주관적인 평가 방법이 두 개를 같이 접목을 시키셨고, 이제 당연히 주관적인 방법이 들어가는 거는 트레이너가 봤을 때 이제 평가를 해서 다음 단계로 넘어갈 수 있을지에 대한 결정을 하기도 하고, 또 수술을 끝나고 나서 그 비디오를 갖고 이틀 안에 다 같이 앉아가지고 평가를 해주시기도 하고, 또 객관적인 지표들을 사용하기도 했다고 하셨습니다.
네, 감사합니다. 이윤석 교수님, 우리나라하고 약간 이 트레이닝 환경이랄까, 볼륨 이런 게 막 차이가 있는데, 혹시 논문 보시고 코멘트 해주실 점이나 그 디스커션 포인트가 있을까요?
네, 저는 한 4개 정도 질문이 있는데요. 첫 번째는 이제 모듈별로 아까 그 러닝 커브가 조금 다르다고 그랬는데, 어쨌든 전체적인 모듈 트레이닝을 받았을 때 이렇게 모듈 트레이닝을 받은 펠로우들의 러닝 커브랑 그렇지 않은 펠로우들의 이전에 이제 컨벤셔널 트레이닝을 받은 펠로우들하고 러닝 커브에 있어서 좀 차이가 있는지, 그런 데이터가 있는 게 첫 번째고요. 두 번째는 이제 모듈을 5개로 나눴는데, 사실은 온콜로직 아웃컴에서 제일 중요한 건 모듈 5, 이제 TM인데 사실은 그 디테일하게 데이터를 보면 펠로들 모듈 5는 굉장히 적거든요. 그래서 모듈 5에 작게 했는데 이걸로 종합적 안정성을 얘기하는 거는 조금 N수가 작은 게 아닌지. 또 세 번째는 좋은 프로그램을 잘 만들었는데 이게 한 센터에서만 하기엔 좀 아까워서 이거를 확산시킬 좀 구체적인 계획을 갖고 있는지 아니면 우리나라를 포함한 어떤 다국적 프로토콜을 만들어서 시행해보면 저는 굉장히 좋을 거라 생각이 되고요. 마지막 하나 질문은 요새 이제 여러 가지 테크놀로지들이 많이 발전되고 있는데 그런 테크놀로지를 여기 모듈에 좀 녹이면 조금 더 좋은 모듈을 만들 수 있는데 그런 모듈을 디벨롭할, 업그레이드 할 수 있는 그런 플랜이 있을지 이렇게 네 개 정도 질문을 좀 하고 싶습니다.
Yeah. All right. So Professor Lee is asking 4 questions. The first question is if there is any data regarding the difference between the learning curve of the trainees who was in this module program and who was not in this module program. That's the first question. And the second question is, we can see that the module number 5 is the most important for making any differences into the post-operative complication outcomes. But as you can see in table 1, the trainees who actually performed module 5 in this study is very small, like 4 or 5 cases. So isn't that a limitation? Like, isn't that a too small of a trainee to actually say that there was no any difference between the expert group and the trainee group? And number 3, the third question is, this is a very good module and a training program. Do you have any specific plans to make it like a multi-center research or a multinational research? Any plans for that? And the last question is that there's so much new technologies nowadays, and it would be very nice to put in those new technologies into these training modules. Maybe he's looking for such like visualization guidance and sort of those stuff. Do you have any thoughts on that?
Thank you so much, Professor Lee. Great questions again, very thoughtful. The first of one, which is comparison between trainees who are trained in the program versus outside the program. I wouldn't have a direct comparison because when we started training people in robotic TME, this was a program we started to get them on the training wagon. So they are the fellows trained in this program. The only nearest comparison will be a program where established consultants are trained by industry in their own hospital setup. So you can have a consultant working in a hospital in Birmingham, and if they want to do robotics, industry will provide case observation and then a proctoring on the job. And I have done a lot of those for those surgeons. And from experience, what that prepares those surgeons is to deal with easy, selected, non-complex cases because the learning curve is still pretty steep for them. While those who are trained in the program, they have seen a breadth of experience in terms of easy and complex cases, and they may have seen their trainers do a lot of complex stuff as well. So that exposure gives them a better foundation. But I don't have a direct comparison because we haven't trained fellows and trainees in a different model in the UK at least. Your second question was about the number of modules, which again, I agree that the TME dissection is the most important model, and that will affect the outcomes for these patients afterwards. As I said before, the numbers of rectal cancers that people do are small, and it's a 6 months program only. So in those 6 months, they get to see about 20 to 30 procedures on the rectum, and they will be part of all of them. But actually, when they're doing the cases, that will be between 5 to 10 modules of the TME. I think in order to reach statistical significance, I would value your comment that we would need more cases because this could have been a chance effect that we have not seen bad outcomes in those cases because the numbers are small. But it was reassuring that at least whichever cases they did, they haven't caused any compromise to the oncological outcomes for those patients. I really like your question about the multi-center nature of this program. I think that is something which will give us the validity outside the UK. We are at the moment in the middle of designing a UK-wide training program based around this for robotics, but it will be great to collaborate with other centers, and I perhaps can count on your support from Korea and other places to see if we can replicate a similar model. I'm sure there'll be higher numbers in modules in the Korean training program, but the question we can ask is, does Korea even need that program? Because, excuse me, you have such a high volume practice, whether it'll be great to hear your thoughts on training as to, do you think that there's a place for such a program in Korean surgical training, or because the volume is so high volume and centralized practice, you don't need that? And the last point very quickly about advanced technologies. I think I'm a very big fan of surgical navigation for trainees. I think it will even improve that learning curve. And there are technologies like Eureka, which can give real-time mapping and intraoperative navigation, ultrasound. There are new molecules coming out with fluorophores, which can give you intraoperative cancer navigation or image overlay in real time. My worry would be like when I see my daughter talking to Siri, asking to do the homework online and not even typing a word in the laptop. We don't want this generation to become too complacent with that attitude. All those aids are great, but you need to have the foundation blocks on your training to really capitalize on that. And hence, I am a bit cautious about introducing them too early in the training, but I think it is something which is beyond our control. The new generation is going to be very much exposed to this as they grow.
Thank you, sir. 첫 번째 질문은 직접적인 비교한 자료는 없다고 하셨고, 그냥 경험상 봤을 때 이 모듈에 들어간 트레이니들이 좀 더 이제 심플 케이스, 컴플렉스 케이스들에 대한 좀 더 이렇게 용이하게 받아들인다는 느낌이 받았다고 하죠. 직접적인 비교는 없다고 하죠. 그다음에 케이스가 적은 거에 동의를 하시고, 그래도 통계 유의하려면 더 많은 케이스가 있었으면 좋긴 하겠지만, 지금 현재 이 결과에 대해서 유의하다고 생각하고 안도감을 줄 수 있는 그 정도의 결과라고 생각을 한다고 말씀하셨고, 지금 다른 다기관 연구에 대해서는 UK 내에서는 지금 진행을 하고 있다고 말씀을 하시는데, 뭐 다른 나라에서 같이 하는 거는 굉장히 좋은 생각이긴 하고, 약간 반농담식으로 말씀하신 거긴 한데, 한국은 케이스가 너무 많아가지고 진짜 꼭 필요하겠냐, 이런 거를 할 필요가 있겠냐, 이런 말씀을 하셨습니다. 마지막으로 뭐 서지컬 내비게이션 새로운 시스템 유레카 울트라사운드 이런 거를 이용하는 거는 굉장히 좋은 거긴 하지만 그 모든 것의 그 새로운 기술에 대해서는 근본이 있어야 된다고 말씀을 하셨고, 그것을 밑바탕으로 탄탄하게 갖고 있어야지 그 이후에 그런 거를 뭐 받아들이는 거를 생각을 해야 된다고 말씀하셨습니다.
Okay, before I open
하나만
the
더
audience.
코멘트.
Okay.
예,
네.
예.
네. 한개 주십시오.
예, 우리나라가 볼륨이 많은 거는 맞는데, 요새는 그 트레이닝 시킬 사람이 없어서 좀 더 체계화된 트레이닝 프로그램이 필요할 것 같다. 저는 개인적으로 생각합니다.
화내지 마. 또
It's about the Korean circumstances. Is commenting on these circumstances. We have lots of cases in Korea. However, we don't have surgeons to train them. But we need some modular training program. He say like that.
For sure, we don't have any
Yeah.
person to need train.
So stop
We can
stop
set the
there.
panel
No
to
train
you.
anymore.
Okay, before I open to the audience program, I briefly ask Dr. Pyoji. 그 청중 질문 넘어가기 전에 피오치 선생님께 간단하게 질문 드리겠습니다. 한국과 영국 두 군데 모두 트레이닝을 경험을 해보셨는데, 네, 양쪽 간의 장단점이 물론 있으리라고 생각을 합니다. 특히 모듈라 프로그램이 가지고 있는 장점에 대해서 직접 느끼시는 어떻게 경험, 어떤 부분이 가장 좋았다고 표현해 주실 수 있을지 한번 해보도록 하겠습니다.
So thanks, Kaspar. So when I was in Korea, I've been there for nearly 16 months, if I'm not wrong. And I was honored to have a limited license. So that was a great honor for me from the Korea University team. Means that I had a clinical access to the patient and I could perform surgery together with Professor Kim Son-an. And that was, I think, a huge honor for me because I was sitting next to him, watching every case from the start to the end and discussing every case. And he trained me exactly more or less similar to what Professor Khan was discussing now. So in a modular way, the same way. So first teaching me what was the port placement, which was a bit different with his case. Then was the dissection on the vein and the artery. Which steps he should have done on the splenic fracture takedown, and at the end the TME or transanal techniques for ESR, etc. So I think I felt like I felt a lot of similarities between the program in Korea that I had and the program here in Portsmouth. And I think the strength of this is standardization. I think that's essential. The fact that both in Korea and here in Portsmouth, every procedure is done with the same steps from the beginning to the end in every case, with very little variations, and the variations are done only when necessary. Otherwise, if you know the technique, if the procedures, you know how to do it and how to position every arm, every instrument, and every angulation, remember the third arm and the camera control, then you don't need to create any variation. There are people before you who have done thousands of cases. So before you decide to introduce your variation, think why the people before you and your trainer has done do the technique that way.
네, 그래서 한국과 그 영국을 둘 다 경험하신 선생님이시라서 차이를 말씀해 주셨는데, 한국에서 김선환 교수님과 같이 수술을 이제 처음부터 끝까지 로봇 수술을 같이 보게 되고, 그런 좋은 시간을 갖게 되고, 모든 것을 같이 디스커션을 하면서 이제 비교를 해 보니까, 이제 와서 보니까 굉장히 중요한 점이 이 모듈 트레이닝과 굉장히 비슷한 수련 기간을 한국에서 가졌다고 말씀을 하시고, 어떠한 모든 수술이 셋업부터 뭐 혈관 결찰, 뭐 스플래닉 프랙처 내리고 TME까지 이런 과정들이 다 이렇게 세그멘테이션 되게끔 이렇게 설명을 해주셨다고 말씀을 하시고요. 또 되게 중요한 게 이게 전부 다 스탠더드데이션 돼 있다는 게 굉장히 중요했고, 모든 그 절차에 루틴이 있어가지고 큰 차이 없이 항상 같은 방법으로 진행을 했기 때문에 좋은 결과들이 나오는 것 같다. 그래서 새로 시작하는 로봇 수술을 시작하는 사람들, 초보, 노비스한 서전들은 만약에 자기가 뭐 어떤 걸 변화를 시키고 싶다는 생각이 들 때 한 번 더 생각을 해야 되는 게, 이제 이전에 경험 많으신 분들이 이미 시행착오를 수천 번 겪고 이런 프로시저를 만든 거기 때문에, 변화를 주고자 한다면 한번 고민을 한번 해보는 게 어떻겠냐 이렇게 말씀하셨습니다.
네, 감사합니다. 이제 그 청중들께 질문을 받도록 하겠습니다. 청중 중에서 질문이 있으신 분은 손드는 굉장히 열띤, 열띤 반응인데요. 지난번에 질문하지 않으셨던 그 이충엽 선생님한테 기회를 먼저 질문을 받아보도록 하겠습니다. Now this topic is open for discussion to audience. It's very many audiences want to ask to you and invite 충엽 리.
네. 혹시 목소리 들리시나요?
Yes, we have you.
네, 안녕하십니까. 저는 서울 아산병원에서 펠로우 중인 지금 이충엽입니다. 제가 드릴 질문은, 이게 트레이니 그룹에서 시간이 더 걸린다는 결과가 나왔는데, 어느 술기에서 이제 전문가분들과 다르게 시간이 좀 더 주로 소요가 되었는지랑, 저도 이제 펠로우로서 배우는 입장이다 보니까 로봇 수술 시에 어느 술기에 좀 더 이렇게 중점을 두고 트레이닝을 받는 게 더 좋다고 생각하시는지 그 두 개의 질문 여쭤보겠습니다.
So this is Dr. Lee from Asan Medical Center. He's a fellow, and he sees that he asks that the difference in the operation time. What do you think is the main module that the trainee experienced the most difference in the time, and that caused the outcome? And also one question is that as a trainee, as a fellow, which model do you think is the most crucial and for the trainee to train on?
Thank you, Dr. Lee. Very good questions again. I think the different stages in your learning curve where different modules may look different. When trainees start on the vessels, for example, the IMA, and they need to know how much traction they are pulling because it can cause some minor bleeding, or under the inferior mesenteric vein, if you're lifting it up too high and you don't have the tactile feedback, you can cause some damage. So there is some hesitation in that vascular module in the early first few cases. But honestly, the most difficult case, again, I will go back, is the splenic flexure module, and purely because to do that well, and if we teach people to do them in single docking, single position, and single setup of port placement, so we don't change things around in order to keep the operating time to a minimum. But that deserves a very specific approach, and you have to be good with the use of your third arm and to be able to create tension when actually the colon and stomach are quite lax. So you have to learn how to display tissues properly, and hence it takes a bit longer for the trainees to do that module. The last part of the question was which module has the most impact on the outcomes. And of course, I think if you're talking of rectal cancer surgery, it will be the TME quality, because at the end of the day, if it is a poorly done TME, you may get a positive margin, local recurrence, or post-operative complications. But if the TME is straightforward, I strongly believe that it is the quality of your splenic flexure mobilization that determines the clinical course for the patient afterwards.
네, 시간과 그리고 그 난이도 관련해서는 역시 마찬가지로 스플래닉 플렉셔 쪽이 제일 어렵다고 말씀을 하신 것 같고, 또 도킹도 계속 중간에 바꿔야 되고 하니까 그런 게 시간이 오래 걸렸다고 말씀을 하셨고, 트레이니 펠로우로서 중점을 줘야 될 거는 첫 번째는 뭐 TME가 제일 중요한 그 렉탈 캔서의 수술 퀄리티를 결정할 요인이기 때문에 중요하겠지만, 그게 솔리드하고 잘 한다면은 역시 난이도 자체 면으로는 스플래닉 플렉셔 내리는 게 제일 어렵지 않나 이렇게 말씀하셨습니다.
네, 감사합니다. 저희가 다음 질문자 모시기 전에 지금 챗에 질문이 하나 올라와 있는데요. 이게 Jim, we have a question on chat. He means excellent conference. How can we help surgeons from South America to attend training with you, Jim and POG? He's from Ecuador.
Sure. I think the world is becoming a very smaller place now. We don't have those boundaries that used to exist 10 years or 20 years ago. So I would say one should try to visit whenever you get a chance. And my advice would be that if you are visiting a country, plan to attend a conference around that time, plan to attend a course, and plan your trip so that you can be in the operating room maybe even for a week. For experienced surgeons, you can learn a lot of tips and tricks by being there for a short period of time. So write to the host and the consultant or the professor and see if they are willing for you to come. And we are very willing in the UK to have visitors coming from anywhere. But equally, don't underestimate the importance of linking up on events such as this. And then I think the near future, you will have lots of opportunities to link up with the operating room remotely. So it is called a virtual operating room. So there will be lots of opportunities from Ecuador, you can link up with our operating room. Of course, there is a time difference and you will have to be maybe up in the night in order to link up with our daytime operating. But you can see all of that from your room, office, study, and look at the whole operation. So there will be a lot of resources on digital platform for watching the practice and the techniques.
굉장히 중요한 질문이고 말씀을 주신 것 같은데, 세계가 굉장히 작아졌기 때문에 놀러 오라 이렇게 말씀하셨고, 어떤 나라에 갈 때 컨퍼런스에 되도록이면 참석을 하고 수술장에 가가지고 한 주라도 이렇게 보면 굉장히 도움이 될 거라고 하고, 편지 쓰고 적극적으로 편지를 쓰고 비지팅을 하고 싶다 이런 거를 피력을 하라고 말씀하시면, 또 가까운 미래에 이제 실제로 같이 동시에 버추얼 오퍼레이팅 룸에서 만날 수도 있기 때문에 그런 가능성도 앞으로 더 열릴 거라고 말씀을 주셨어요.
네, 그러면 들으시죠. 정원범 교수님 아까부터 기다리고 계신데 정원범 선생님 인바이트해서 질문 들어보도록 하겠습니다.
Yeah, maybe may I answer here? there is a very nice question here from Dr. Sang
Chat.
Vietnam. If we can, it's very important because I had this experience in Korea and here now in England. One of the main difference actually in patients is the high BMI, which is unfortunately maybe the real pandemic here in the West, especially in the Anglo-Saxon countries, let's say, so UK, US, etc. And we have definitely a lot of patients with a very, very high BMI. This means that it's quite challenging for the surgeon, not only for the trainee, but also for the consultant. And you can see the difference between expertise between different consultants. So performing surgery on a high BMI means having a lot of momentum, meaning having the mesenteries, which are quite redundant, meaning having all this epiploic fat coming around, which makes it so complicated. So that's why it's so important. First of all, the first step is the correct positioning of the patient. So use the right angles. The technology now with the XI system, for example, for the Da Vinci, is the possibility to do a table motion. So the possibility to change the positioning of the patient during the surgery without redocking the system. And again, is the fact that you have to be very, very careful when you perform surgery because when you have a lot of fat, you can't identify correctly vessels, for example, the marginal artery. Therefore, many cases we used here, and Prof is one of the biggest experts, I think, the use of intracorporeal echography. So the use of the echography inside with a probe inside the abdomen and wheeled with the instruments. And this allows you, especially, for example, for right hemicolectomies, to identify the main vessels, which are key in performing a right hemicolectomy with CME. But the same can be for left colic resection, so identifying the right vessels where they are in the middle of all the redundancy of the fat. So that's a very good question.
채팅창에 올라왔던 질문에 대해서 답변을 해주셨는데, UK에 특히 서구 쪽에 이제 BMI 높은 애들이 너무너무 많기 때문에 그거에 대해서 강조를 해서 말씀하셨고, 첫째는 수술 시작 전에 처음 세팅하는 자세, 포지션이 중요하고, 두 번째는 수술 중간에 자세 변화하는 것도 도움이 된다고 말씀하셨고, 당연한 얘기지만 이제 extra careful, 더 조심스럽게 수술을 접근을 해야 되고, 수술 중간에 쓸 수 있는 기술들, RCG 등을 사용해가지고 메인 베스를 확인하는 방법들이 있다고 말씀하셨어요.
네, 저희 청중에서 두 분 모셔서 질문 두 가지만 더 받겠습니다. 정원범 교수님, 그 다음에 수장 갈란디기 참전을 하셨는데요. We have two more questions from audience. Is one from 원범 정 and the last one from the 수장 갈란디. She has a question to you. Okay, let's at first 원범 정, Professor 정.
안녕하세요. 지금 한국의 현대백병원의 정원범이라고 합니다. 저는 질문이 하나 있는데 이 연구를 진행할 때 이제 그 로봇의 듀얼 콘솔로 마스터 슬레이브 방식으로 연구를 진행했는지 아니면 콘솔에 안 치고 옆에서 코멘트 하시면서 연구를 진행했는지 굉장히 궁금합니다.
So he's Professor Jung from Beck Hospital in Busan. He's asking if the study was performed with a dual console or a single console. Yeah, that's a question.
Thank you, Professor Jung. It's a very important point, and we didn't make enough emphasis on this. I strongly believe that dual console is a great learning tool, and all these procedures were done with the dual console training because you can see a same view. I think the example I always give is the learning driving. You wouldn't learn driving with a dual control learning driver car. So here we are teaching complex surgery without having the same view and the same control. It is expensive, but I think if you're into a teaching hospital scenario and setup and trying to teach fellows, you should have every effort to have a dual console to improve training experience.
듀얼 콘솔로 했다고 중요하다고 말씀하셨어요.
Thank you. It's a very short summary. And Sujan, we are very welcome to your question.
No, I was just, Professor Khan, I was just concerned about the volume numbers you mentioned. And do you think, what is the minimal number of rectal cancer cases you think a surgeon would need to maintain quality results and competency? And do you think there's a difference in robotic procedures versus open or laparoscopic?
Well, you kept the best to the last, Professor Ganelik. That's a great question. And I think I will probably put my presidency hat from our national society, which is the ACPGBI, and I'm pushing really hard for big numbers for rectal cancer surgeons. I think there is a reason for a volume, and I think as a rectal cancer surgeon, and it does not matter how you do them, open, robotic, laparoscopic, the disease biology, behavior, complications, rescue options, all those things matter when you're dealing with cancer such as rectal cancer. And it is a very evolving field. I think as a surgeon, you should be operating at least on one rectal cancer per week, which means that it should be about 30 to 40 for a surgeon in a unit to do that. And if you're doing less than that, you should either give up or join with a different unit or centralize those. So again, between 20 to 40 is the number. Our national guidelines suggest that each hospital should be doing 20 rectal cancers and in order to keep that service going, but that is 20 for the hospital. If you have 5 consultants in that hospital, that is very dismal figure. And if I break it down that way, it shows that we have 5 rectal cancers per surgeon per year in the UK, which is not which we are very proud of. So hopefully we can change that landscape and aim for something around 1 rectal cancer every week, if not every 2 weeks.
굉장히 중요한 질문을 수산 선생님께서 해주셨는데, 볼륨 넘버가 너무 중요한 것 같은데, 로봇 오픈 복강경 뭐 상관없이 얼마만큼의 그 한 서전이 1년에 렉탈 캔서를 해야 좋겠냐 이런 건 질문을 해주셨고, 지금카 선생님은 직을 걸고 볼륨이 중요하다는 거를 강조를 해주셨습니다. 본인의 직을 걸겠다고 하셨고, 본인 생각에 로봇만 케이스가 중요한 건 아니고 로봇이든 복강경이든 오픈이든 상관없이 볼륨이 굉장히 중요하고 지금 UK 유나이티드 킹덤 내셔널 가이드라인에 따르면 한 병원에서 1년에 20개의 렉탈 캔서는 적어도 해야 된다고 말을 했는데 만약에 그 센터에 의사가 렉탈 서전이 5명이 있다면 한 명이 5개, 4개에서 5개밖에 안 한다는 거기 때문에 굉장히 너무 적은 가이드라인이라고 말씀하셨고 본인 생각에는 지금 계획 구체적으로 이제 이렇게 세울 것 같이 말씀하셨는데 20에서 40개 한 명당 렉탈 캔서를 해야 되지 않겠나 이렇게 말씀하셨습니다.
Every 2 weeks.
네, 감사해요. 굉장히 핫 디스커션이어가지고요. 마지막으로 시간이 없습니다만 채세 올라온 질문까지 하고 마무리하는 걸로 하겠습니다. 지금 we have one more question on chat. Can you see the questions?
Yeah, I can see the question here, so I might read it. So how do you manage time for residents and fellows to optimize their training, since robotics is not the only thing that they need to learn? So that's very important. I think I always think, and when I write the papers, that robotic is an approach. We always say robotic surgery, but it's a robotic approach. So it's a way to perform a surgery. So it's not superior, inferior. It's just a way to do it. But it's the way that is becoming slowly, now at a higher pace, the mainstream in many countries. So definitely it has to be, is needed in the training. Unfortunately, it's not in the training as I did in Italy. Also in the UK, it's not in the training. So that means that you have to spare time from yourself, spare some funds, unfortunately, if it's not funded, to join courses, to join training programs, which usually are quite expensive, unfortunately. Now, many societies are providing better training, and I think training should be under society and not under industry. And I think the best way possible is to join a fellowship. That means having 6 months at least assisting an expert surgeon anywhere in the world, anywhere you feel comfortable, and being able to have a clinical experience. And this has to be associated also to a research experience, because I think training on the robot and only learning how to use it doesn't mean anything if then we don't know why you're using the robot, what's the purpose of using the system, and what are the benefits for the patient. We shouldn't do robotic surgery to everyone. That's only ideal case. So we have to think when we should use it, why we should use it, since that's how you should work, especially for us that we work in an NHS or in a national healthcare system. So training is essential, it's difficult. We at the moment still, it has to be based on your will and interest to, unfortunately, spare your time and energy, your family, and funds at the end. hopefully the
And
future is better.
second question has to go to Jim. Okay.
Same question, sorry. Yeah.
Second question maybe has to go to Jim.
Um,
He want to send his fellows and
okay, no, that's
residents
for the
to you.
colleagues.
Yes,
So
yes. Same one.
I think,
Yes.
yes,
Yes.
definitely, it's a great
Okay.
idea to exchange fellows, and I'm a big fan. I always tell my fellows to visit other units, and what we should do is set up an exchange program, even if it is for a shorter time, because by seeing a different practice and seeing how things are done, they can gain a lot. So having an agreement between hospitals or between societies to do a mutual traveling fellowship for the trainees. I'm aware of some Aussies and some Americans doing this, where they actually exchange even their houses. They just stay in each other's house for 3 months or 6 months, and hence that keeps the costs down. So very welcome to have any fellows in the UK. Similarly, I will encourage my fellows always to go to Korea and to US to visit other centers. And I think the last comment about the timing and management training between robotics and other things, I think at the moment, robotics is a kind of a niche area of training. But the way things are changing, we are going to get to a point where the other methodologies will disappear slowly. We're already seeing that many trainees don't know how to do good open surgery because they are trained in laparoscopy that well, that many of my trainees don't do an open appendicectomy or an open hernia repair. And I think give them 5 years or 10 years more, and they would have forgotten how to do it laparoscopically because robotics will become the mainstream. So, but that's natural evolution, and it is going to happen whether we like it or not. We just need to be prepared and go with it.
간단히 정리해 주십시오.
네. 펠로우
네.
시간 관리에 대해서는 PO치석의 박 선생님이 설명해 주셨는데, 예, 로봇 교육에 대해서 이제 받기가 아직까지도 조금 완전 편하지는 않다고 말씀하셨고, 제일 좋은 방법은 펠로우십에 들어가 신청을 해가지고 하는 게 어떻겠냐. 가족도 희생하고 돈도 써야 된다 이렇게 말씀해 주셨고, 여기 보니까 교환 그거에 질문을 해주셨는데, 사실은 한국에 갈 수 있냐고 질문을 해주신 것 같은데,
아, 정말요?
네. 네, 뭐 어쨌든 이제 센터 간에 익스체인지
그러네요.
프로그램을 만들고 뭐 학회 간의 교환 프로그램을 만들고 이런 서로 막 집까지 바꿔서 이렇게 하는 그런 접근성까지도 보인다고 해주셨으니까 충분히 그거는 이메일을 하고 뭐 PI 연락하고 하면 될 수 있을 것 같습니다.
Yes, I misunderstood the last questions from the audience. I'm sorry for that. It's time's up. It's time to close this session. We very thank you for joining this DCR Korean Journal Discussion Forum. It's very honored to have you guys this forum. Thank you, Jim Khan.
Yeah,
Thank you.
Thank you. Have a good day.
예.
Bye.
네,
Thank
저희는
you. It was good to see you.
수고하셨습니다.
네, 저희 아직 안 끝났고요. 저희는 일단 모두 수고하셨습니다. 저희가 이제 3월에는 일본 선생님을 모시고 재밌는 세션을 꾸려볼까 합니다. 파라웨팅 노드에 대한 세션을 마련하고자 하고요. 3월 18일에 뵙도록 하겠습니다. Thank you, Jim. Thank you, Piotr. And thank you, all panelists and
Thank you.
audience.
Bye.
Good night and good afternoon. Thank you. Thank you, Sujan. Thank you.
수고하셨습니다.
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 김현 선생님, 감사합니다.